From Robert Wood Johnson University Hospital, this is Medically Necessary.
Welcome to Medically Necessary, the official podcast of the Robert Wood Johnson University Hospital medical staff. I'm Chris Hoenig, joined as always by Dr. Jim Salwitz. Dr. Salwitz, happy 2021.
Yes, indeed. Another wonderful day in the medical neighborhood, as you're loved to say.
Or as I guess we would call it right now, December 44th of 2020, because it really doesn't feel like 2020 has ended for us, has it?
Well, we're still going through more than a number of trials here, but we'll get through it.
Speaking of trials, what a perfect segue here into our first conversation we're going to have. The COVID-19 vaccines, maybe that light at the end of the tunnel of actually feeling like it's 2021. The vaccines are out there now for healthcare workers. We've had the clinic here at Robert Wood Johnson University Hospital up and running at full speed. We've been starting our second doses of the Pfizer vaccines. We are doing first doses of Moderna vaccines for the staff that are getting their vaccines now. Nearly 300 people a day at its peak going through that clinic. So working as hard as we can to vaccinate as many people as we can, as safely as we can. And at this point, I'd like to welcome in our first guest, Dr. Tanaya Bhowmick. Dr. Bhowmick is one of our infectious disease specialists, part of the Rutgers Robert Wood Johnson Medical School. And Dr. Bhowmick, thank you for joining us today, first of all, and welcome back.
Thank you for having me, and thank you for the welcome back.
Yeah, I understand you were out with bearing child, I believe.
I bore a child in the middle of the pandemic. Yes.
So you came back in November, right?
I came back in November, yes.
Right. You heard it was quiet around here. There was nothing to do, so you decided it was time to come back.
Yeah. There was a little email here and there. Baby's doing well. Baby's growing well, yeah.
Well, congratulations. Very exciting.
Thank you.
We wanted to bring you on and really focus today on the vaccines. Obviously, there is a lot going on, a lot of stuff all over the news about vaccines right now, and really just let's arm with information. So right now on the market, emergency use authorized by the FDA are the Pfizer and Moderna vaccines. Very similar trial results for these two vaccines, correct?
Yes, very similar and both very effective and very impressive. More than 90% efficacy for the two trials, 95% for Pfizer and 94% for Moderna.
That's pretty incredible when you think about that ability to prevent an illness that is so lethal.
And you might think, well, that seems too good to be true. But we have other vaccines that are pretty effective as well, like hepatitis A is up there in the high 90s. So you can't say that this is completely made up, or this is believable because we have other vaccines that are equally or even with greater efficacy.
And if I'm correct, at least with the Pfizer vaccine, 2 weeks after the second vaccine, they actually reported no new infections, right?
Yes, that's very exciting.
Pretty mind-blowing.
This is also just keeping in mind that it's still very early on in terms of seeing the long-term outcome, but still, this is really exciting news.
These vaccines are and I hate to use this term new, so I'll put new in air quotes, technology, the mRNA technology. This is stuff that has been studied for decades. We were very close to an Ebola vaccine utilizing this technology. But I think because of its air quotes newness, there's a lot of apprehension about the technology. How does it work?
Normally within a cell, there's DNA, like for human cells. And then that DNA gets transcribed and then it moves out of the nucleus of the cell. It goes into the cytoplasm. And that's where different proteins are made. This vaccine is providing you that transcribed piece of RNA. This vaccine is delivering a roadmap for the cell to make proteins, and it goes directly into the cytoplasm. So you don't have anything going into the nucleus of the cell, which is where the human body has its own regular genes. There in the cytoplasm, it creates these proteins, and the proteins get released. The protein, or the spike protein, which everyone has heard about in the news, is what is exposed on the cell and the body sees this and develops an immune response. And that spike protein is what's seen on the actual coronavirus. When you get the vaccine, you're showing your body the spike protein, but not the actual virus. So that in the future, if you're exposed to the virus, it'll recognize that spike protein from the vaccine and will know how to react to it so that you don't end up getting sick.
Is there any concern that the spike protein that the vaccine has your body make could itself be a problem?
No. So the spike protein that is part of the virus, that is part of what the vaccine is going to make, is not something that our own bodies have. So there isn't any danger of this vaccine causing an attack on your body.
So a couple of important points then. First of all, the vaccine does not in any way become involved in the primary instructions in your body, your DNA. It has nothing to do with that. And there is no mechanism that RNA becomes DNA. And that just doesn't happen. So it can't affect the primary instructions. And then, of course, the other thing is the protein that your body is making for a while because of the vaccine, the spike protein, is completely foreign. And so it becomes a foreign enemy that you're teaching your body to attack.
Exactly.
So what I thought was incredibly elegant about this vaccine is that the vaccine is against the spike protein. And the spike protein is critical for the functioning of the virus. If the virus tries to change, mutate, become different in some way, it can't get rid of the spike protein. If it gets rid of the spike protein, it's no longer infectious. I mean, eventually maybe we'll see something, but we know from the early information about the couple of new, more aggressive mutants we're hearing that they're still susceptible because the spike protein is still critical. And the other thing, of course, is you're making a vaccine against something completely foreign to the human animal, spike protein, which is not, despite what my hair may look like now, is not something natural, to any part of the human biology. So it's really an elegant vaccine, truly brilliant way of protecting us.
But I think that really brings up an important point, though, because there has been a lot of confusion about this vaccine because it's a new technology. I'm sure that plays a large role in it. And one of those pieces of confusion has been that, can it edit or change your DNA? And so the fact that this focus is that this is really about the spike protein and working within the RNA, within the cytoplasm, not involving the nucleus of a cell. That is very important. In the other area, there's a lot of confusion about this. And one of the reasons I want to speak to you, especially Dr. Bhowmick, a new mother, there is a lot of confusion about whether this vaccine can cause infertility in women, sterility in men. Is there any evidence that points that direction?
No, there isn't. There is some thought that the spike protein is similar to some other protein that is needed for the attachment of the placenta to a woman's uterus when she's pregnant. However, those proteins are too dissimilar for that to actually be a valid point. As Dr. Salwitz was alluding to, this is a completely foreign protein, the spike protein that we're seeing on the coronavirus, and that's part of the vaccine. If anything, there's the concern that actual infection with COVID-19 could result in some inflammation, some what we call orchitis, inflammation of the testicles. When we see this with like mumps and with EBV, so we've seen it with other viruses. So if someone wants to preserve their or their family, their partner's fertility, the best thing would actually be to get the vaccine to prevent infection.
So again, to repeat what you just said, the vaccine is the best way to avoid being potentially harmed, sterilized maybe by the disease.
Correct.
Because that's a very important point. I mean, this is extraordinary illness can cause an extraordinary amount of number of different kind of injuries. And as you're pointing out, the disease itself may have a real risk of causing problems with fertility for a number of direct and indirect reasons going forward.
Yeah.
Those important points.
Now,
have you gotten your vaccine?
Yes, I did. I actually got my second shot today.
Oh, did you? I had my second shot yesterday.
You beat
me. And it's, I don't even, not even really a sore arm. So, I mean, maybe a little tired today, but I was working last night, so I'm not even sure that's relevant. But yeah, no, very, very simple, very straightforward. It's potentially empowering. It really is.
I had a little bit of a sore arm the first time. This time, I think it might still be too early, but if I push, I feel it. Otherwise, I'm not really feeling much in terms of pain or any other side effects.
Excellent.
And I think that's another important point. There have been side effects obviously reported with both vaccines, but for the majority of people who receive them, they are no different than what you would experience after getting a flu shot or other vaccines that are out there and proven.
An interesting point about fatigue, of course. The fatigue from the illness can last for months, the so-called long haulers, while the fatigue we're talking about with the vaccine is what I probably am feeling a little bit today, is the next day you're a little tired and then that's it, which is a drastically different outcome, for everyone. It really is.
Yeah, and a study just released recently. We had a link to it last week in, I believe it was Friday's MedStaff email, that the loss of taste and smell with those who have just mild COVID symptoms, 86% experience that, and it can take up to 6 months to really fully recover from that. So a day of fatigue versus unknown severity of illness, and even if you only have mild symptoms, still battling in some degree potentially for months after infection.
Right. I think that same AMA article, as you referred to, Chris, talked about on depression. Depression also is a secondary emotional. If it's just, say, I can't taste your hot dog, big deal, but it's a gigantic part of what we are. And I think it really pointed how devastating that kind of long haul secondary injury can be.
Definitely a multifaceted disease and one that can be very devastating from many perspectives. And also, an interesting point here before we go to our quick commercial break, it was this week 1 year ago, January 14th of 2020. If you have that MedStaff newsletter in your archive, there was a little blurb in there that the CDC and New Jersey Department of Health were closely monitoring a cluster of pneumonia of unknown etiology with possible links to a large wholesale fish and live animal market in Wuhan City, China. And the advice there was just watch out for patients who may have respiratory symptoms that had traveled to Wuhan since December 1st of 2019. So it has been 1 year this week since we first started to discuss what we now know as COVID-19 right here at RWJUH. Obviously another month plus before we saw our first patient come through the hospital. But it's been a year that this has now been part of our reality here at Robert Wood Johnson University Hospital.
And you heard it here first.
And it's amazing to think of what has been accomplished in that year as well.
Absolutely. Absolutely.
In terms of finding the genetics for this virus, developing a vaccine, developing or having several studies looking at different therapeutic options.
And the massive work in restructuring how we provide medicine, whether it's Zoom, whether it's people keeping people safe on the front lines. This continues to be a real tragedy, but on the other hand, I think we've come a long way. We've learned a lot, and we will get beyond it soon.
Well, Dr. Tanaya Bhowmick, thank you so much for joining us. Coming up, we're actually going to talk about one of those therapeutics, monoclonal antibodies. A lot of questions we've been receiving here from especially our primary care community. Who is eligible for it? What are the criteria? We're going to sit down with Dr. Rob Eisenstein, Chief of Emergency Medicine, and get those answers. We'll be right back.
As part of RWJ Barnabas Health, Robert Wood Johnson University Hospital has a nationally ranked heart transplant program, is at the forefront of innovation in heart surgery and research, and has nationally recognized cardiac programs for excellence in transcatheter valve replacement and minimally invasive surgery. So get your heart checked, because your heart doesn't beat just for you. Robert Wood Johnson University Hospital. Let's be healthy together.
Medically Necessary, the official podcast of the Robert Wood Johnson University Hospital medical staff.
Welcome back to Medically Necessary. Chris Hoenig here as always with Dr. Jim Salwitz. Last week, we talked about the research into COVID-19 that has gone on here at RWJ and how critical that is to the academic mission. But it's also important to remember that there is so much more to the academic mission than just the research. There's the training, there is the teaching that goes on, there is being at the cutting edge of medicine as an early adopter of treatments and protocols that are developed elsewhere as well.
Yeah, I think that's your point. Our standard of excellence, should always be right at the limit. Not only providing the best care that can be provided, no matter where it was developed, but also studying that and improving upon and developing it ourselves. It's absolutely critical about who we are.
And speaking of that early adoption, I'd like to welcome in the Chief of Emergency Medicine here at Robert Wood Johnson University Hospital and Rutgers Robert Wood Johnson Medical School, Dr. Rob Eisenstein. Dr. Eisenstein, it is great to see you. Happy New Year.
Thank you, guys. Thanks for having me, and Happy New Year to both of you as well.
It's always nice to have you on, Rob. You've been on several times before, and we learn a lot from you. We get a lot of requests to you. Let's hear Rob again. Let's listen to you guys. So thank you for coming on board and setting us right.
Well, let's also point out that, one of the last times we had you on here, we did a video interview during our video updates during the COVID surge, and we conducted that hidden away under a stairwell.
Right.
And it just kind of crammed in. It had a beautiful backdrop for the video, but everybody was ducking and we had to climb over rails to get underneath the stairs. So thank you for your flexibility with all this. And I'm sure you enjoy doing the podcast a lot more where you can just sit in a comfortable chair and not have to duck around stairwells.
Well, Chris, in working in the emergency room, I'm used to getting into whatever spaces I need to. So that's not a big deal for us.
Now, Chris, is under that stairwell where you actually injured your ankle, or was that somewhere separate?
That was before I injured my ankle. So, I don't want to say it contributed to it, but
all right.
I'm not as flexible as I was then now. We'll put it that way. We talk about the early adoption of treatments. And one of those treatments, of course, for COVID-19, the monoclonal antibodies. And that is something that we have taken on here at Robert Wood Johnson University Hospital. It's a unique treatment that we get a lot of questions from, especially from the primary care community, in terms of how do we get our patients, what patients qualify? And so it's important to note that these antibodies, you can't just write a prescription for them and go to a pharmacy and get them. You play a very integral role in all of this, Dr. Eisenstein.
Maybe we should start exactly what are these therapies, Regeneron product or whichever product we're using, what are they?
One, I want to start by this was, been a system-wide fantastic effort to get this up and running. And it was a collaboration between emergency medicine and pharmacy at the system level and at essentially all of the sites throughout the system. There's what's called, and it's happened for other treatments for COVID-19, things that have been given emergency use authorization. So this is not something that's necessarily FDA approved yet, but there are two monoclonal antibody products, one by Regeneron, which is imdivimab, I believe is how you say it, and the other is a Lilly product called bamlanivimab, that are essentially, for all intents and purposes, the same thing, and they're essentially a man-made or created antibody to specific proteins on the COVID-19 virus. The preliminary phase 2 trial done with these drugs showed some suggestion that there is a decreased risk or a decreased incidence of hospitalization or return visits and requiring hospitalization for this patient population. And there was enough of the thought there that, again, this emergency use authorization was given for both products. At the system level, again, there was a lot of work done in essentially acquiring both products. So we've had access to both of them. We started with the bamlanivimab, and after, I don't know how many, I guess it was late November, around the 22nd or 23rd is when we gave our first dose, and it's taken me about that long to be able to actually say the name of the drug after saying it this many times. But we here have given probably over 95 as of, I think, December 24th, 90 plus doses of that. The other Regeneron product, which I'll use the company just because it's easier than trying to say those names. What we've done is we've given probably, I want to say 15 to 20 doses there. And the way, again, in this effort, the system has gotten an allocation of both drugs, and they have been providing it and allocating to the various sites based on use, essentially. So one, I think, making this therapy available at a system level was a great lift. or a tremendous lift. And we're also unique in that I, as part of being in an academic department of emergency medicine, I'm on a listserv and a group with all the academic chairs of the emergency departments throughout the country. And although many systems have gotten involved in starting to provide this therapy, there are very, very few. In fact, in the email thread that I was involved with this, there was probably 2 other emergency departments that were actually providing. Everybody else was doing this via outpatient infusion centers. So we are unique both in the scope, doing this system-wide, and doing this in the emergency departments. I think that's a great idea there. We are currently working actually with our colleagues up at Newark Beth Israel and our friends at New Jersey Medical School in Newark to work on how we can actually look at our outcomes, looking at doing a sort of retrospective study on who's come in, who's gotten these drugs, who's required admission, and trying to see how much information we can get to compare potentially the treated to the not treated patients, as well as even, potentially looking at the 2 products and seeing if there's a difference. So that sort of is in the works as we talk about the academic medical center and the benefits there. We're working on trying to collaborate with the rest of the system and the sites to be able to use data across the system. And just to put that in perspective, we in New Brunswick in the adult ED see roughly 70,000 patients a year. And if you take that system-wide, we're talking, and include universities, 800,000 patients a year. So the access to data system-wide is incredible. And if we look at the total doses we've used, it's, we gave 90 here. It's probably closer to 1,000 doses across the system of the medication. So it's a huge benefit in terms of numbers to look at.
Tell us a little bit about who qualifies, what the process is.
Essentially, there's a few things you have to do to be a candidate to get the drug. First and foremost, obviously, you have to test positive for having COVID-19. If patients arrive that are symptomatic, we will test them in the ED. We are having patients sent to the ED who are candidates from their provider, from their primary care providers. One thing I will say, and we'll ask if you, and I'll talk more about who should come to the ED, but make sure that if someone is being sent and if they've had a test done elsewhere, ideally bringing the result with them will make life a lot easier, because we do want to confirm that the patients are positive before going down this route. And I had at least one case where someone was sent in saying, oh, yes, they were positive. But when I actually talked to the patient, their wife was positive. They hadn't been tested yet. So it would have been very, not the greatest thing if we just sort of assumed, sure, you have your test and given it to them. So that will help in terms of timeliness and not having to wait to repeat a test here and conserve resources. So in addition to being positive, it also has to have a symptom onset within 10 days. So if your symptoms have been gone for longer than 10 days, you don't qualify for the use of the drug. And you have to be well enough to go home and not requiring any oxygen therapy above any baseline oxygen therapy you've been on. So people that we had been traditionally sending home from the ED saying, come back if you get worse. Now, again, I'll go further, but there's a patient population that we can actually give this medication to, and hopefully the likelihood of them coming back and requiring admission will be lessened by giving it. So again, we said 1, COVID positive, 2, symptoms onset less than 10 days and well enough to go home. But then you do have to meet some other high risk criteria to do that. So first is age 60, over 65. Anyone over 65 in itself makes you a candidate for the drug. Next is if you're over 55, but also have associated either hypertension, coronary artery disease, or pulmonary disease, you would qualify. And then if you're under 55, you have to either have diabetes, be immunocompromised, or have a BMI of greater than 35. So if you have those things, you would qualify. We are getting patients sent from PCPs in the community here, but we've also had patients sent from further to come here because we have this therapy that not every place in the state is doing. I mean, I was just speaking to our system vice president for emergency medicine I was on a call with this morning. They've gotten calls from other places. I got a call from Atlantic, saying, hey, how are you guys doing this? Because there haven't been, this hasn't been done. So we're definitely ahead of the curve in terms of making this available. If you do see somebody, have a patient in your office that ends up testing positive and you want to send them to the ED, we do ask that you call ahead first. That way we would have a conversation with you to do 2 things. 1, confirm that they actually are a candidate for the therapy. and second, to make sure that we actually still have, drug available to give. Right now, we have a fair number of doses of both drugs available, but we're probably averaging 6 doses a day given to patients up or down. So and shipments they come as allocated, so we never quite know. As and the way we're deciding one drug versus the other is bamlanivimab was the first available, so essentially we use that until we run out, then we'll flip to the other, and as soon as we get that back in stock, we go back to that again and continue. And that way it makes it easier, and since honestly we don't know if there's a difference, there's no need for the provider, let me flip a coin and pick. We just know if we have the bamlanivimab available, we use it. If we're out, we flip to the other. And I do get a daily count, and it is announced at the safety huddle, which I do listen to every morning, how much drug we have available. So I'm keeping an eye on it. But it's important to call, because if for some reason, the supply chain stops and we stop getting it and we run low, I really hate for someone to be sent to the ED to say, I know you came for this drug, but sorry, can't help you. And now they just got, ended up sitting here waiting and dealing with that for nothing more than being sent back home, because there's really nothing else we can offer at this point.
What in theory should we be achieving with these patients? I mean, I hear we're going to look at our patient population stuff. What improvements should we be seeing?
So, I mean, the ultimate goal really is, is decreased need for hospitalization. And that's what we're primarily looking at. From looking at the paper myself, there's some thought that the viral load may decrease a little bit quicker. There's some thought that symptom duration, may get a little bit better. But from what I can tell, it's not a huge difference overall. In terms of, it looked like day 7 to 11, I think, is when you started to see a little bit of a difference. But by that point, most people were already getting better anyway. So I think that the biggest hope is, the rate of return. And we did have that. It was never huge, but there was some people who go home saying you're on the fence, you're not sick enough to be in the hospital, who end up coming back, 24 hours, 48 hours a week later. Now they are worse and require hospitalization to get sicker. So really the goal is hoping to prevent the progression more than anything else, so that they don't get sick and don't need to be hospitalized, and they go home and recover.
So I don't know if you saw this in Southwest West Virginia. They accidentally gave 42 people the Regeneron antibody IM instead of the vaccine. It was a simple error. Fortunately, this apparently, other than wasting the antibody, doesn't harm these people at all. But the first thing when I saw that 42 is I said, what in the world is the cost of that?
Yeah, good question.
So what does this therapy cost?
Honestly, I don't know the answer, and I don't know how much was being supplied for use. I know from the hospital side, there are specific charges associated with the drug, and when we do administer the drugs, it's a 1-hour infusion. So I can't imagine even that, if it's 1-hour infusion, what an IM injection might do. And then we do an hour of observation afterwards. And the biggest, and I should have mentioned that earlier, is the biggest concern is anaphylactic reaction to it, which we have not seen yet. And from my call this morning, I don't know that anybody in the system has seen any actual issues at this point. So again, we've given out a fair amount, and there doesn't seem to have been any bad reactions that we're aware of.
Of course, in oncology, we use a lot of monoclonals, and every now and then we'll see someone react. A true anaphylactic event has been pretty rare, so hopefully it will continue to be rare with this. Stepping back a little bit, how is the emergency room doing with this second wave, if you will? It's a lot less more of a swimming pool at this point because it's been going on so long. But yeah.
So it's a very different environment now than it was before. In some ways less challenging, in some ways more challenging. First, the truly high acuity, very, very sick patients that we were intubating sort of left and right, that hasn't happened. We're not seeing people quite as sick in high numbers as we did before. The flip side to that with respect to COVID is we also don't have the same number of that low acuity patient that we would just, when we had our tent open before in the last round, we were seeing roughly 30, 40 patients a day that had potential COVID-like symptoms that we saw through this tent, sent home after looking at them via telemedicine without them ever making it into the ED. This go around, we have a few triage bays out in the waiting room, and we sort of set that telemedicine equipment up in one of the triage bays. We're only seeing 6 or 7 patients a day that would have fallen into that same category. So it's a different patient population. It's much more in that we're sick enough to be in the hospital, but not necessarily sick enough to be intubated group than we had before. So that's a different approach. The overall volume in the ED is not quite recovered to a sort of normal. And when I say overall volume, I'm talking about arrivals per day. We're still only hovering around 85-ish% of the volume we saw pre-COVID. However, that 15% we lost is primarily in the lower acuity patient population. So our sort of fast track, or CIA area, as we call it, that's where the volume drop off has occurred. The main ED is probably pretty close to where it had normally been. And the struggle we're facing that's truly different in terms of hospital operations this go around compared with last is last time, there was an executive order and everything shut down. There was no elective procedures. So in terms of admissions and entry point into the hospital, we were a one-man show. Everything coming into the hospital came through us, and there was no competition for inpatient resources. Well, this time we've continued to perform surgery, and the operating room's continued, the cath lab has continued. So the typical competition for beds that we have on any given day is still there. Layer on the complexity of COVID and trying to maintain, it's been talked about the two hospitals in one, sort of a way of managing sort of the non-COVID world and the COVID world. Adding those two things together is created a much bigger challenge in terms of length of stay of admitted patients in the ED when we decide they need to stay, to be able to get a place in a bed for them to go to, both one, waiting for test results to come back, and then just the logistics and the availability of bed to go to, whether it's a COVID or a non-COVID patient. The challenge is still there. So that is taken and really made it, although the overall arrival of patients is lower, the census in the ED at any given time of day is very, very high. And it's probably been much higher than in under normal circumstances, just because the length of stay is that much longer.
And have you noticed a difference in the number of non-COVID patients that come in? During the first surge, so many people were staying home. It seemed like many people were afraid to come to a hospital.
Mm-hmm.
So, maybe not coming into the ED when they would have otherwise. And then when they do come in, they're a lot sicker. Have you seen a difference in that?
So there was definitely a bounce back to some degree. Yeah. Last time, you're right. Every other sort of illness sort of disappeared, like completely disappeared. Not only the low acuity, but the people with strokes and coronary artery syndrome, it all is essentially evaporated. Again, we were down to about 50% of our normal daily volume during last time. We're back up to 85. So we did have had a return of that sicker population, less of a return of the real low acuity patient population, and the acuity and the number of patients that are coming in is definitely higher. So what we're seeing is fewer patients overall, still seeing the breadth of illness that we sort of lost for a while, but the acuity is higher. So the patients are much sicker. So we're even though, again, our overall volume is down by 15%, the number of patients admitted per day is roughly the same as when we were at a higher volume.
Any message that you would push out to med staff, its community at this point, about the best way to support the emergency room staff at this time, things that we should just be aware of, in this unusual situation?
And I think, obviously patients who need to come to the ED need to come to the ED. We want them to come to the ED. If you have concerns with respect, obviously your patients who end up being COVID positive, we discuss sort of, who to send and to make sure they're aware of it. I think, the best we can do as patients are in the hospital, recognizing what has to happen in the hospital. And I have this conversation in the all the time is it safe for this person to go home and have whatever they need done as an outpatient? Does it truly need, require hospitalization? I mean, it's changed over time how long people stay in the hospital and how much has to get done. We really need to think about that because inpatient beds are a scarce resource. And although we want to keep them full, we need to use them wisely and really think about who's coming in and who's going there. The other thing that I stress with my guys and everybody else is remaining, in terms of protecting ourselves and our patients and remaining vigilant, even though the vaccine is here and many of us are, about to go, have had our first round and are getting ready to get the second. We still need to maintain as a group that we're maintaining PPE, maintaining our social distancing, doing what we need to do. Because I think one of the things we've seen is some people ending up positive here and there after a very long time of doing well. I think a lot of that has to do with a little bit of fatigue and people sort of saying, hey, we're at the end of the game, we've got the light of the tunnel, and they're becoming a little lax and making sure they're protecting themselves. And I think if nothing else, we all need to make sure we continue to do that. The vaccine being here is not the end all be all, and it's going to be quite some time before enough of the population is vaccinated to have a true meaningful impact, that we all need to make sure we're doing that, encouraging our patients to do the same. The other thing is a reminder that, visitor status and that visitation is limited, so that people know that ahead of time before, coming in and feeling frustrated when they can't have visitors under, in a lot of circumstances. So I think that it makes life a lot easier. People know that ahead of time, recognizing that the stresses that are also, if you are sending patients in, the better understanding they have of things take time, that there's a lot going on. We're doing what we can to keep people safe. And in that effort, some things do take a little bit longer. And it may be, if you need to stay in the hospital, that you're in the ED a little longer than you would like. But if people know that ahead of time, it's much less frustrating than finding that after the fact.
Good advice. Good advice. Interesting time. It sounds like you're doing a tremendous job, Rob. Thank you so much. We really appreciate it, and the update as well as the science around the antibodies. It's very interesting. We learn a lot. Thank you so much.
Absolutely. Thank you. And again, I'm always here. People have reached out early on with questions about what we're doing, how things are. I think everybody knows how to reach me. I'm always available.
Excellent.
Dr. Rob Eisenstein, Chief of Emergency Medicine here at RWJ. Thank you for joining us.
All right. Thank you, guys. Take care and be well.
Take care.
As always, you can subscribe to Medically Necessary through all your favorite podcast platforms. We're available on Apple Podcasts, Google Podcasts, Spotify. You can catch us through a link on the Robert Wood Johnson University Hospital Medical Staff Portal, and we are available on YouTube. For Dr. Jim Salwitz,
For Chris Hoenig,
thank you for listening.
Medically Necessary, brought to you by the Robert Wood Johnson University Hospital Foundation.